Hello guys, I am Shalika welcoming you to the show Pharmacy and Medical Crash Course Division in the Knowledge Club online. At previous episode, we learned about reasons of heart failure and classification of drugs for heart failure. Today, we will learn about the drugs for heart attack and failure, the renin-angiotensin blockers. Heart failure leads to activation of the renin-angiotensin system via two mechanisms. Number one, increased renin release by juxtaglomerular cells in renal afferent arterial occurs in response to the diminished renal perfusion pressure produced by the failing heart. And number two, the renin release by the juxtaglomerular cells is promoted by sympathetic stimulation. The production of angiotensin 2, a potent vasoconstrictor, and the subsequent stimulation of aldosterone release that causes salt and water retention leads to the increases in both preload and afterload that are characteristics of the failing heart. In addition, high levels of characteristic of the failing heart, angiotensin 2 and of aldosterone have direct detrimental effects on the cardiac muscle, flavoring, remodeling, fibrosis and inflammatory changes. Know more about this? Stay tuned up to end, because if you skip the lecture, you can miss our valuable points in between lecture. So stay tuned up to end. I am going to start today's episode. Let's start. Number one type of drug is the angiotensin converting enzyme inhibitor. Angiotensin converting enzyme means ACE inhibitors are the agents of choice in HF. These drugs block the enzyme that cleaves angiotensin 1 to form the potent vasoconstrictor angiotensin 2. These agents also diminish the rate of bradykinin inactivation. Memorize it. The vasodilation occurs as a result of the combined effects of lower vasoconstriction caused by diminished level of angiotensin 2 and the potent vasodilating effect of decreased bradykinin. Okay. By reducing circulating angiotensin 2 levels, ACE inhibitors also decrease the secretion of aldosterone, resulting in decreased sodium and water retention. The mechanism of action. The actions on the heart, that is, the ACE inhibitor decrease vascular resistance, venous tone and blood pressure, resulting in an increased cardiac output. ACE inhibitors also blunt the usual angiotensin 2 mediated increase in epinephrine and aldosterone seen in heart failure. ACE inhibitor improve clinical signs and symptoms in patients also receiving thiazide or loop diuretics and or digoxin. The use of ACE inhibitors in the treatment of HF has significantly decreased both morbidity and mortality. For example, we can see as the ACE inhibitor enalapril decreases the cumulative mortality in patients with congestive heart failure. The reason behind it, the reduction in mortality is due to primarily to a decrease in deaths caused by progressive heart failure. Treatment the enalapril also reduces arrhythmic death, myocardial infarction and strokes. Similar data have been obtained with other ACE inhibitors also. Indications. ACE inhibitors may be considered for single agent therapy in patients who present with mild dyspnea on exertion and do not show signs or symptoms of volume overload. ACE inhibitors are useful in decreasing heart failure in asymptomatic patients with an ejection fraction of less than 35%, that is at the left ventricular dysfunction. Patients who have had a recent myocardial infarction also benefit from long-term ACE inhibitor therapy. Patients with the lowest ejection fraction show the greatest benefit. Early use of ACE inhibitors is indicated in patients with all stages of left ventricular failure with and without symptoms, and therapy should be initiated immediately after myocardial infarction. Pharmacokinetics. All ACE inhibitors are adequately but incompletely absorbed following oral administration. The presence of food may decrease absorption, so they should be taken on an empty stomach, except for captopril. ACE inhibitors are products that actually require activation by hydrolysis via hepatic enzymes. Renal elimination of the active moiety is important for most ACE inhibitors. Here, also an exception being fosinopril. Plasma half-lives of active compounds vary from 2 to 12 hours, although the inhibition of ACE may be much longer. The newer compounds such as ramipril and fosinopril require only once a day dosing. Adverse effects. These include postural hypotension, renal insufficiency, hyperkalemia, angioedema, and a persistent dry cough. The potential for symptomatic hypotension with ACE inhibitor therapy requires careful monitoring. ACE inhibitors should not be used in pregnant women because they are fetotoxic. Some common ACE inhibitor drugs are captopril, enalapril, fosinopril, lisinopril, quinapril, benazepil, moixifril, perindopril, ramipril, triamcinolone. P denotes the product. Active metabolites produced by deesterification of the main drug. Second type of drugs are angiotensin receptor blockers. Angiotensin receptor blockers (ARBs) are non-peptide, orally active compounds that are extremely potent competitive antagonists of the angiotensin type 1 receptor. Losartan is the prototype drug. ARBs have the advantage of more complete blockage of angiotensin action because ACE inhibitors inhibit only one enzyme responsible for the production of angiotensin 2. Further, the ARBs do not affect bradykinin level. Although ARBs have actions similar to those of ACE inhibitors, they are not therapeutically identical. Even so, ARBs are a substitute for ACE inhibitors in those patients who cannot tolerate the latter. General mechanism of actions on the cardiovascular system. All the ARBs are approved for treatment of hypertension based on their clinical efficiency in lowering blood pressure and reducing the morbidity and mortality associated with hypertension. As indicated that their use in heart failure is as a substitute for ACE inhibitors in those patients with severe cough or angioedema. Pharmacokinetics. All the drugs are orally active and require only once a day dosing. Losartan, the first approved member of the class, differs from the others in that it undergoes extensive first-pass hepatic metabolism. Including conversion to its active metabolite, the other drugs have inactive metabolites. Elimination of metabolites and parent compounds occurs in the urine and feces. The proportion is dependent on the individual drug. All are highly plasma protein bound, that is greater than 90%, and excretion happens for candesartan have large volumes of distribution. Adverse effects. ARBs have an adverse effect profile similar to that of SAA inhibitors. However, ARBs do not produce cough. ARBs are contraindicated in pregnancy. Some common types of drugs used as ARBs, that is the losartan, valsartan, irbesartan, candesartan, telmisartan, eprosartan, olmesartan. So with today's lecture up to this, next episode we will discuss on drugs, the rest of the part of heart failure. Revise the all episodes on heart thoroughly. I made it step by step accordingly. Here the all previous episodes list on heart anatomy and physiology chapter and cardiac pharmacology chapter. You will get all links at the discussion part of this video, or you can visit our channel. Before ending today's episode, if you like this video, please like, share and comment freely. Don't forget to subscribe our channel. If you already subscribed, then thanks a lot. And after subscribing our channel, please click on the bell button for getting the regular updates of Knowledge Club Online. I am coming with another episodes very shortly for you. Till then, goodbye.